Well, welcome everyone. I know that there's probably still people joining us, but out of respect for everyone's time on a Friday evening, we want to get going right at 6 o'clock. So I'm Dr. Christina Francis, and I'm a board certified OB-GYN who currently practices as an OB hospitalist here in Indiana. I'm also the CEO of AAPLOG, the American Association of Pro-Life OB-GYNs, and an associate scholar with the Charlotte Lozier Institute. For those of you who aren't familiar with APLOG, we're a national professional medical organization that represents more than 7,000 medical professionals across the country who practice medicine from a life-affirming standpoint and who prioritize the care of both of our patients when we're caring for pregnant women, both our maternal and our fetal patients. And joining me today is my co-host for this evening and good friend and also APLOG board member and our advocacy team leader, Dr. Susan Bane. Dr. Bane has practiced obstetrics and gynecology for 25 years, including in private practice at Greenville Obstetrics and Gynecology and serving as clinical professor at the Brody School of Medicine at East Carolina University. She's currently the medical director at 3 pregnancy centers in Eastern North Carolina, where she oversees the medical aspects of the centers and serves patients with unintended pregnancies. She has testified before her home state's legislature in North Carolina. She's also been married for 36 years to her husband, Art, and has 3 children, including one with special needs, and 3 grandchildren, including one who may be making their entrance into the world tonight. So if she seems a bit distracted, that may be why. She's waiting for that call. So the title of tonight's event is Managing Pregnancy and Beyond with Trisomy 18. A curbside consult stat. The reason we chose this title is because, as many of you know, last week, a tragic news story broke out of the state of Texas involving the pregnant mother of a baby who was diagnosed with trisomy 18 in utero, and a lawsuit that was filed asking the state to allow her to obtain an abortion. As the story developed, we realized that there was a lot of confusion surrounding prenatal diagnoses and how physicians can navigate difficult situations like this in a life-affirming way, respecting the needs and the dignity of both the pregnant mother and her preborn child. There also seems to be ongoing confusion over whether or not physicians can intervene in states where pro-life protections have been passed, like Texas, when a woman is experiencing life-threatening pregnancy complications. And so we realize that there is great need for medical experts and people who have a personal experience with these issues to offer some clarity here. In the medical community, we use the term curbside consult when we ask our colleagues for recommendations and insights on how to think about a tough clinical scenario that we might be dealing with. And so that's what we're hoping to offer you today. Actionable insights for you to use in your life affirming work, whether you're a medical professional or a pro-life advocate. Over the next hour or so, you will be hearing from our special guests, a neonatologist who will give us an overview of what trisomy 18 is and how he manages patients with this condition and also supports their parents. A maternal fetal medicine specialist who will discuss how he cares for pregnant mothers after a trisomy 18 diagnosis and how he walks them through understanding that diagnosis. And also the parents of a teenager with trisomy 18 who will share their personal story and insights on what people should know about having a child with this condition. I want to note that these guests all agreed to be interviewed at very short notice, so we are so grateful for their flexibility and their generosity of sharing their time with us. We will have staff monitoring the chat throughout this event, so please, if you have a question, feel free to drop that in the chat. We'll try to answer as many audience questions as we can, but we may not get to all of them tonight. So with that, let's get into it now. My co-host, Dr. Bane, is going to be introducing our first guest before he joins us for his interview. Dr. Bane?
Well, thank you. I had the pleasure of interviewing Dr. Marty McAffrey. Dr. McCaffrey is a professor of pediatrics at UNC Chapel Hill in the Division of Neonatal Perinatal Medicine. He's a retired captain in the U.S. Navy and served as the director of neonatal care at the Naval Medical Center, San Diego, and a consultant to the U.S. Navy Surgeon General for neonatology. Dr. McCaffrey has a strong interest in the care of infants and children and the support of families dealing with challenging prenatal diagnoses. He has published on the topic and is recognized as an expert in this area. As a member of Support Organization for Trisomy, or SOFT, and the Be Not Afraid medical boards, he has offered medical support to hundreds of families dealing with difficult prenatal diagnoses. So we're going to listen to his interview now, and I know you'll enjoy hearing from him. Dr. McCaffrey, thank you for joining us.
Oh, it's a pleasure to be here, Dr. Bane. Thank you.
So I want to start, just share with our audience, what is a neonatologist? What's your job?
Yeah, sure. Well, a neonatologist is someone you're a pediatrician, but then you subspecialize and you go through extra training, which equips you to take care of critically ill infants and newborns. And the range is pretty wide for what that covers. It's a lot of what we do is related to premature babies, but also includes babies with other types of anomalies and defects or just respiratory breathing issues that we couldn't have predicted. It's not infrequent that what we do is dealing with a baby that was a delivery that everyone thought would go fine, and then things didn't go so fine for some reason. So that's why we're there, and we're called to the delivery room to stabilize and evaluate babies.
Thank you for that. So in terms of when you talk about babies who you take care of, one of the types of conditions that you take care of is babies that have trisomy 18. So can you share with us more about trisomy 18?
Sure. Yeah. Trisomy 18, I think, obviously, in the current climate, people have become a little bit more familiar with maybe, but trisomy 21 may be something that many more people are familiar with, Down syndrome. But after Down syndrome, which is the most common genetic anomaly that we see, there's trisomy 18 and then trisomy 13. And trisomy 18 and trisomy 13 are a bit different than trisomy 21. They're much more complicated medical conditions oftentimes for the babies. But every baby is different and every baby is unique. And really the ability of babies to be supported and do well and survive and have long lives potentially really depends on their individual medical conditions. That these are conditions, trisomy 18 is quoted to occur in about 1 in 5,000 births. So far less common, for instance, than Down syndrome, which is about 1 in 800 births, 1 in 700 births. So seen much more commonly, also seen much more commonly trisomy 18 in moms who are a little bit older and more advanced maternal age. And that's very similar for things like Down syndrome as well as trisomy 13. So trisomy 18 falls into that category of the trisomies, but may have some very different and more challenging medical conditions associated with it.
So what are some of those challenges that these kids may have, or babies?
Sure. Well, very commonly, trisomy 18 babies will have cardiac conditions, and it's estimated that anywhere from 80 to 90% will have a cardiac condition. That doesn't mean all of those are conditions that need to be operated on, and those are conditions which vary in severity, actually, and can be similar to some of the heart conditions we see in babies with normal chromosomes, who we have very well-established treatments for and we do quite well with in terms of the babies who might have a condition in that state that needs an operation. The other conditions that babies with trisomy 18 will have include things that may be related to the bowels. There may be issues related to breathing. And one of the great fallacies, I think a lot of us who work with babies with trisomy 18 believe it has been sort of enculturated into neonatology, is that babies with trisomy 18 have sometimes a condition called apnea, which many will say is central apnea. What has become clear over the last 5 to 10 years that many of these babies actually have an anomaly of the airways where they have obstructive apnea. And so the obstruction is what makes it hard to breathe. That's what apnea is. And it's not necessarily related to a central brain problem. which is kind of important because in the past, I was raised this way. And for many years looked at babies with trisomy 18 as babies who had a lethal, quote unquote, condition because they would come out and oftentimes they wouldn't breathe. And that may manifest over days or weeks after they're born. And in truth, what it seems a lot of that is not a function of brain not being able to help the baby breathe, but airway obstruction. And we have ways to treat that as well. So the point being, I guess, that every trisomy 18 baby is different and unique. And there are many different medical conditions that can be encompassed under trisomy 18. But it's very, very hard to really put them all in the same bucket. And what we've realized over the last 10 years, for sure, through the literature that's been published, is that the way I was trained, and through 2009, which was when my epiphany occurred, and I met a number of families who had children with trisomy 18 and trisomy 13, my belief was that this was a lethal condition. And that belief still persists until today, and it's simply not true. What experts, multiple experts across the neonatal world and the pediatric world and the ethics world will now say is that trisomy 18 is a life-limiting condition. Indeed, there are children and adults who are in their single-digit years, their teen years, in their 20s and their 30s with trisomy 18. The one thing that is unifying for individuals with full trisomy 18 is that they will have severe mental and motor impairment. And that can be a little bit variable as well, but they are severely impaired individuals. And so that's something I think we have to keep in mind in terms of how we think about this condition, is if the medical conditions are treatable, but the developmental conditions are not, what is really leading us to believe and persist in saying that these conditions are lethal when we know that these individuals are capable of surviving?
Yeah, thank you for that. When I was in residency in the 90s and we had, a baby born with trisomy 18, it was almost like automatically you would not do any interventions.
Right.
And it sounds like that's very different. So can you talk a little bit about like what life expectancy is and how that is impacted by whether or not we treat them medically like we would a child with a heart defect without trisomy 18?
Right. I mean, that's a great question. That's a pivotal question. And this is from the literature. I mean, I have a lot of anecdotal experience with this, but the literature will tell us now. And if you want to pour back through it, back in 2016, published out of Canada in JAMA, was a study of infants with trisomy 18 and trisomy 13. And what is fascinating in that study is if you look at survivals for trisomy 18 at a year, it's in the teens. But what is notable is that when you look at survival of babies who are alive at a month, the survival in that study was 38%. So that's hardly a condition I would call incompatible with life. I mean, we obviously have many cancers that people unfortunately encounter where survivals are far lower than that. We never call them lethal, incompatible with life. More recent data has shown that babies with trisomy 18 who receive medical interventions, which could be a range of supports, it should not be believed that every baby with trisomy 18 to survive needs massive medical intervention and ventilators and surgeries and will live their whole life in a hospital. That there are some cases that may be the case, but that is definitely not all the cases. And so what we're seeing now in more recent literature over the last year, actually, that's come out of Cincinnati Children's in this country, is that survivals are as high as 50% for children with trisomy 18 at 1 year who receive interventions. The Japanese community has been very engaged with trisomy 13 and 18 over the last several decades. And what they are showing with medical interventions is survivals up to 70%. And so these are medically complex children. I don't want to paint the picture that these are well children who are developmentally normal. That is not the case. But I think what is really critical, Dr. Bane, is that what we need to be talking to parents about is transparently and openly the potential for life for these children. And that is not generally happening. We know that through the literature, and I know it through extensive anecdotal experience that I have in counseling families. And the literature that has been published would suggest one really concerning fact, that the factor most associated with the chance that a baby will die in the hospital with trisomy 18 is a prenatal diagnosis. So when a prenatal diagnosis is made and a family wishes to continue the pregnancy, what occurs in most cases, in this study out of Canada as well, is that parents go down a road that is called variably comfort care, hospice care, or palliative care. Those terms are not interchangeable, actually. Palliative care implies, yes, we acknowledge there's potentially a life-limiting condition, but we will provide ongoing medical care that may extend life and extend quality of life. Hospice and comfort care are probably fairly synonymous for most people's vocabularies. And what they found in this study from Canada, Annie Janvier was the lead author on this, a neonatologist, as well as her husband, a neonatologist, as well as a mother of a child who died with trisomy 13, Barb Farlow. What they found is that when there's a prenatal diagnosis of trisomy 18, most commonly the course is comfort care within the hospital, hospice care. And what that consists of is mainly warmth, narcotics, and bereavement support. And so when that is all that's supplied to a baby, the end result is that most of those babies die in the hospital. The flip side of that study was that babies that were diagnosed after they were born would have a variety of interventions made before a diagnosis was made. So at day 7, after supporting a baby for a number of days, what one might get is a trisomy 18 report back that is positive, but now the family has seen the baby, they know the baby can survive, they haven't been told that the baby is lethal or incompatible with life. And so palliative care really occurs for many of those babies, and the medical care that takes place for them takes on a very different look, where many of those babies may survive to get out of the hospital, certainly many more than those who have a prenatal diagnosis.
Well, that's fascinating. So when you talk about parents not being really told about what the potential for their life of their baby will be once the baby's born, are you referring to like just a really solid, thorough, informed consent? Is that where you see some limitations in your field?
This is all about informed consent to me. That hits the nail directly. That hammer is right down on that nail. That's what this is about. And there's some difficult cases going on now. My prayers go out for the family dealing with these challenges. It's a very, very difficult situation. And people will make different choices. I personally would hope that they would choose life for their baby, but I understand they may make other choices. But what I would hope is, as a physician, that one of the foundations of the medical care that we deliver, informed consent, would be present and delivered to these families. And that parents of babies with a prenatal diagnosis like this would be given counseling that would let them know what the possibilities for life are. It's very common, as I said, that babies will have heart defects in these cases. And then once a diagnosis of a chromosomal disorder comes back with trisomy 18 and what may be a VSD, which is not uncommon heart defect for us, parents are led down a road very often, not always, but very often, of, well, your baby's going to need heart surgery, it's trisomy 18, is going to be developmentally severely impaired. And it's not uncommon in my experience that parents are actually offered and asked if they would like to schedule their abortion the day of that diagnosis. So I think what we need to do is really take a hard look at ourselves and say, are we doing true informed consent? And I'm not sure we're doing that as well as we need to.
Yeah, yeah. So as we finish up, when you think about resources for parents, and of course that informed consent is a primary resource, but can you think of other resources that would be helpful for families?
Yeah, I think there are. I think, the movement, and certainly even the American College of OB-GYN has certainly advocated for this, has been towards parents who would wish to continue these pregnancies to think about perinatal hospice, which, as I described, is generally in most cases going to be offering narcotics, warmth, and bereavement support for families. And I'm not saying that that isn't potentially something that should be really strongly considered for babies with really serious medical complications related to their trisomy 18, but many do not have that. So what I would say is that, and the parents that I encounter, what they have taught me is they've been forced to go look for alternative supports. And Facebook provides multiple trisomy 18, trisomy 13 support for trisomy websites, which will offer parents a bit of a different view of what potentially could be life for their child. I would also offer an organization that I work with called Be Not Afraid. We're at www.benotafraid.net. And we are a group that has taken on the challenge of trying to support parents with difficult prenatal diagnoses of all types get through a pregnancy that they wish to continue, but they haven't been able to find the medical support to do it, and then continues working with them after the baby is born, whatever their decision is for that child. So a fair of the families that we work with are families dealing with trisomy 18 or trisomy 13. But this is work that I think is really critically important. And my hope is that other organizations will pick this work up as well and be able to walk with these families and offer them the case management and the real true support that they need, spiritually, psychologically, and medically, to give them some alternative views about what might be possible.
Well, Dr. McAffrey, thank you so much for the care you provide these children, their families, and the time you've taken to educate us on this important issue.
Well, thank you, Dr. Bane. It's a privilege to be here, and the work is a privilege as well.
Well, that was a privilege to get to learn from Dr. McCaffrey in those, I think, 17 minutes or so. But one thing particularly, Christina, was when he said in 2009, I had an epiphany that it's not a lethal condition. It's just simply not true. And, I think one of the biggest examples was when he was talking about the apnea that the babies had, and that they thought it was central, so it was mediated somewhere in the brain, right? But it was actually obstructive. And when that obstruction was fixed, the babies did much better.
Yeah, absolutely. Yeah, that struck me too when he said that about having that epiphany, because I think for so many of us, you mentioned it when you were talking to him, but for so many of us who are physicians, who are products of our training, I think many of us had that same epiphany of realizing that maybe some of what we were taught about these conditions actually is no longer true. It might have been true at one point that there wasn't much that we could do for these kiddos, but as with so many things, I think about babies born on the cusp of viability, that babies at 22 weeks never used to be able to survive. But now that we've said, hey, let's put our heads together, let's figure out good ways to treat these kids, now some of these kids are surviving. And so I think so many of us have gone through that same journey and that same epiphany. And, the other thing, before we move on to our next guest, the other thing that really struck me was when he said that the factor most associated with a lack of survival for these babies is a prenatal diagnosis. That
Yeah.
if we don't know before these babies are born, and then they're born and we actually try to treat their issues, that so many more of them will survive. And this is something that we grapple with as a profession, right? Is the ethics of some of these prenatal tests. And that's beyond certainly the scope of what we're dealing with tonight. But I think it's good for people to understand that these tests often serve as a death sentence for these children. And we're going to talk a little bit later about maybe the parents haven't received complete information, but I do think that that's an important thing to consider. What Dr. McCaffrey said, he's a doctor who's taking care of these babies every day, who knows that when you actually give medical interventions, not all of them will survive, but many of them will survive. And we need to be sure that parents are informed of that.
Yeah, most definitely. And I think in the chat, we had some people who are interested in getting some of the studies that we cited. So we'll make sure that happens too.
Absolutely. Absolutely. I think now we're going to talk to an obstetrician about diagnosing trisomy 18. So Dr. Bane, I'll let you take that introduction.
Okay. So our next guest is Dr. John Thorp. He is the McAllister Distinguished Professor in the Department of Obstetrics and Gynecology and Division Director for Women's Primary Health Care at the University of North Carolina School of Medicine. He's also a professor of maternal and child health in the School of Public Health. Dr. Thorp is the medical director and founder of the Horizons Perinatal Substance Abuse Program. He has more than 33 years of superb clinical research and academic service for which he has received numerous honors. Professor Thorp helped start the Global Women's Health Division and launched the first obstetrics and gynecology residency in sub-Saharan Africa. So we welcome Dr. Thorp. Well, Dr. Thorp, thank you for joining us today.
Well, I'm honored to be here.
Well, we're going to talk about your work as a maternal fetal medicine specialist, and especially when you're working with patients, your maternal patients and your fetal patients who have a diagnosis of trisomy 18. So, before I ask specifically about that, actually, what is a maternal fetal medicine specialist?
It's an obstetrician and gynecologist who has a subspecialty certification in the care of mothers and fetuses or unborn babies with underlying diseases or high-risk conditions.
Thanks for clarifying that. So I'm a general OB-GYN. I did 4 years of training like you, but then you went on for further training in that area. Okay. Well, let's go ahead and start talking about trisomy 18. So tell us how was that diagnosed during pregnancy?
Well, up until the past decade, it required an invasive test like amniocentesis or chorionic villus sampling. And because those procedures had a fetal loss rate, they were reserved for women at higher risk. There is a bit of an age gradient, not like as pronounced with Down syndrome, and then with various birth defects. In the past 10 years, free fetal DNA from maternal serum has come to the forefront. And the three major trisomies in humans that don't tend to miscarry early, trisomy 13, 18, and 21, can be identified with those technologies or suggested. Positive diagnoses, really meaning diagnoses of those trisomies, need to be confirmed by an invasive test. But that's really changed the game around, and a lot more of these babies or fetuses are discovered, and they're discovered a lot earlier in pregnancy than they once were.
So now with the change in technology, a woman can actually get her blood drawn and have this screening test. And then if that's positive, doesn't mean that her baby or fetus has trisomy 18, but then you can do the diagnostic test. Is that what I'm hearing you say?
It means that there is a 70 to 80% chance that her baby has that. So if somebody were gonna do something dramatic like into pregnancy, you would want to confirm it. But it can be diagnosed much earlier. The tests that North Carolina Medicaid pays for, that a lot of insurance carriers pay for in my state, can happen at 10 weeks. So people can get results by 11 weeks.
So what's the benefit for someone if they had the positive test that showed that increased risk for them to do the diagnostic test? Or does some women choose not to do the diagnostic testing?
Well, many people will say, I'm not going to do an invasive test because it puts my fetus or baby at risk, whatever the small risk is, of an amniocentesis or chorionic villus sampling. 1 in a couple hundred is what's typically quoted. Other people, particularly who are going to terminate or end a pregnancy, want to have it confirmed before they make that difficult decision.
Okay. So let's say that diagnosis has been made, and you're going to counsel a woman about her baby, her fetus, who has trisomy 18. Tell us a little bit about that conversation you have with people.
Well, in the ideal world, there was a conversation before the person decided to have the testing over what their intentions and at least their preliminary thoughts of what they would do with an abnormality, with a trisomy. Unfortunately, the testing often occurs without that conversation taking place, or with minimal information and thought. A lot of my patients want the early test that'll tell them whether it's a boy or a girl, and aren't really thinking that what the test real intent is to give them information about these trisomies that then puts them into a very, a difficult decision and a really tough position for a mother and a family to be in. So after the diagnosis, I really think that the whole industry and when I say industry, I mean the testing is offered by Fortune 1000 businesses. The internet is full of all discussion about screening and diagnosis, but not a lot about what would this look like if I want to stay pregnant, or I don't want to terminate. And it's almost like with the diagnosis, pregnancy becomes disenchanted. The joy and the hope and the compassion sort of go away, and the fetus with trisomy 18 suddenly becomes not a person and not my child, but a problem to be dealt with, almost like a malignancy or an abscess, something that's not wanted. So I think the role of the maternal fetal medicine specialist, or at least particularly with parents who are considering continuing pregnancy or very much want to continue, is to sort of re-enchant that, and to say in a variety of different ways, although your baby is sick and your baby has a condition that is certainly going to result in a shorter life and not the picture of health during that life, it doesn't mean that you need to do something. You know, we can take care of you and take care of your baby and make the best of the difficult hand that you have been that you've been dealt in this pregnancy.
Yeah, at AAPLOG, we really believe women should be empowered with information. And as I listen to you, it sounds like even before the women take their test, there is this gap in information that they should receive. I mean, I've had patients who will just order it online, as you talked about with industry, and really don't get much in terms of understanding the consequence of what the results may show. So on that end, we have to do a really good job helping women understand the purpose of the test, and then afterwards, how we talk to them. So, I think I've worked with women in my general practice who have had this diagnosis. And I mean, it is a major moment of having to pivot from what you thought your pregnancy was to now what you're hearing from the medical field. And, it's so important what they hear. And, as you think about you and your colleagues and sharing information, when parents are scared that, they're scared in the moment, they're scared during their pregnancy, they're scared for the future. Talk to me a little bit about how you really think the approach needs to be. You've mentioned some, but when a family gets that diagnosis and they're moving forward in their pregnancy, we know that some of the families will want to naturally move forward and have the pregnancy have its natural outcome. And that natural outcome may be to give birth, or they possibly could have a stillborn. Talk to me about the options a family has if they choose that they don't want termination.
Well, they can definitely continue their pregnancy. I think it's really important to treat their fetus like a human, a human with a serious illness, a terminal illness, but in some sense, we all have a terminal illness.
We're all going to die. Yeah.
And to try to work with them to optimize or maximize the health of their fetus. There are a bunch of things that people need to think about and work through at the medical level. A huge proportion, maybe 80+% of these babies will be growth restricted. So do you handle their growth restriction like you handle other growth restrictions or not, with antenatal testing, with earlier delivery, then route of delivery, these babies intrapartum can show some really weird monitor strips, be very difficult to interpret, have a higher rate of being stillborn during labor. Do they want to have a cesarean section? Do they want to monitor or not to monitor? Sort of what exactly do they want to do, and how do they play this out?
So it sounds like it's teamwork from the standpoint of, you and the patient, but also other colleagues in the medical team. Who are some of the other members of the medical team that might be involved while a woman's pregnant to help?
Well, I think her first circle of her team is her family and friends. And how do you explain this to your children? How do you explain this to your mother-in-law? How do you explain this to your friends? And if you have children, the children of your friends. There's a whole pregnancy works so well that there's an assumption that everything is going to be okay. And now this person knows that everything is not okay. So how does she communicate at that level? And then in the office, I think, the front desk, the nursing staff, how do they speak about this baby? Do they speak of it as another baby? Have you thought of a name? Or are you going to do a nursery? Or are you going to do a gender reveal?
Right.
There's all of that. And then in labor and delivery, what are the nurses, in my situation, the residents and fellows, that my other faculty members that I practice with, what's going to be their attitude? So I think decision making and planning, this might be the actual place where a birth plan does some good, because hospitals and practices are arranged, have planned for healthy babies and healthy mothers, and with minor deviations. But in this instance, do I want fetal monitoring or not when I'm in labor?
Yeah.
And if I want fetal monitoring, how do I want responded to? Do I want position changes in oxygen and hydration, or do I want a cesarean section?
Yeah.
And so it's a big communication and teamwork sort of thing. It does not work well when it's done in isolation, and it's really not, I don't believe, fair to patients to make them have to be in opposition.
Yeah.
I think another thing that a family needs to start working on is finding a hospital-based pediatrician or neonatologist that will work with them. What birth defects would you address or not address? What would you place a feeding tube or not? How much resuscitation would you attempt or not attempt? And if their baby lives and goes home, then they need a home pediatrician, because these children get earaches and croup and all the things that other babies
Right.
get. And somebody who's going to be, I recall a patient from rural North Carolina, and her baby with trisomy 18, say a month old, had an earache, and the pediatrician refused to treat it because the baby had a lethal condition, and wouldn't give some amoxicillin. So I think they need to start that work, and
Right.
it requires a lot of support, and it's not so much medical and technical as much as it is communication, teamwork, and letting people work through these scenarios of what they want to do, what they think is best for their baby with a serious question.
Yeah.
And that may be the good part of the early diagnosis, is that there is time to ponder and to work and to think.
So I want to start off, as Christina and I talk a little bit about this, first by thanking both Dr. Thorp and Dr. McCaffrey for joining us. They're both academic physicians and very busy. And one of the things that I think is important is they've both come to share with us, not as representatives of the University of North Carolina, Chapel Hill, but as representatives of their own selves and their own practices and beliefs. So I want to touch on a few things that really hit me when I was talking with Dr. Thorpe. I think it could easily get lost that he said that women who have a baby diagnosed with a chromosome abnormality can continue their pregnancy. And I think one of the things that has happened, particularly as people have talked about the Texas case in the media, is this concern that just because you get a diagnosis, then that's a reason to terminate your pregnancy for your own health as the woman. Yes, we know that when people do have a variety of diagnoses, some risks can happen, but we've never in our training been taught that you treat that with an abortion. It's always been you do your job. You actually treat the complication, and I think that's a real strong message we want to get across tonight. Is a woman who has a diagnosis of trisomy 18 or something similar can continue her pregnancy. So that's one of the things for me. And I think the other big thing for me that really a light bulb went on when he used the word industry, and he talked about how our patients sometimes go to private industry as opposed to their doctor or healthcare practitioner, and they order a test that has such huge consequence. And yes, they may want to order it because they want to know, is it a boy or girl? But they're going to find out about the chromosomes, right? And it's not like you're getting your finger pricked and you're getting a hematocrit result back, which matters. But this really needs not to be disconnected from an informed consent. And we need to just be aware and not take it lightly when our patients say, oh, I already ordered that online. We need to have conversations with them about what the consequences of that. What's your thought on that, Christina?
Yeah, absolutely. Well, and I think the thing that stuck out to me from what he said, but also from conversations that I've had with patients or even with my own friends, is that oftentimes when this blood test done, even in their own doctor's office, they aren't always given full counseling before they get this test of what this really might mean, and thinking through all those things like what Dr. Thorpe was saying. And so I think, for those of us who are medical professionals, that's a good challenge to us. To us, that test might seem routine, but to these families, it has potential lifelong implications for them. And so really talking through that before they ever even have the blood test, or certainly, before they would order something online. And, the online thing is similar, I think, to what we're seeing right now with abortion drugs that are being ordered online, where they're, like you said, it's completely disconnected from informed consent. And this is really not the medical care that we should want for any woman, any family, any patient of ours to have. I think the other thing that really stuck out to me was when he said that a big part of how we should be taking care of these patients involves communication and teamwork. And how are we communicating with our patients as medical professionals? It broke my heart, as I'm sure it did yours, when he said that once these parents receive this diagnosis, oftentimes then their child ceases to be a person, and that sort of enchantment of pregnancy is removed, and now all of a sudden it's just all about I'm sorry, and not celebrating any of the joys of pregnancy, any of the joys of parenthood anymore, but really that things just become about taking care of a problem now
Yeah.
and not taking care of your child. And I think he gave us really good pointers, though, of how those of us who work in the medical field can better support these patients through their pregnancies and through their deliveries. Even thinking about how are we handling things on the labor and delivery unit? How are families interacting with them, or friends interacting with them? I think one important point that I would want to make is that we should be emphasizing the value and the worth of that child, even though this child might have a potentially life-limiting diagnosis, that we should still be acknowledging their value and their worth. And then the other thing that stood out to me that I think is a common thread that we're hearing so far from Dr. McCaffrey and from Dr. Thorp is that these children with trisomy 18 should be given the same kind of medical care that a child without that diagnosis is given. To not treat an ear infection simply because a child has trisomy 18, or to not fix a structural problem with their jaw, to relieve an airway obstruction simply because they have trisomy 18 is really medical negligence and abandoning our patients and our duty as physicians. And so that leads us, I think, very well into our next guest, who can speak to just how important it is that children with trisomy 18 receive the medical care that they deserve. They can also talk about, and they're going to talk about, how difficult sometimes that medical care is to find. So let me introduce you to the Smith family. Before they join me, Brad and Jesi Smith are going to join us with their 14-year-old daughter, Faith, who is just a joy, as you all will see. Faith was suspected of having trisomy 18 in the womb in 2008 and then diagnosed 2 weeks after birth. Since then, Mr. and Mrs. Smith have fought tirelessly for their daughter, not only against the serious health challenges posed by her condition, but also against the forces within our nation's healthcare system that have denied Faith and other children the respect and care that are offered to able-bodied children. The Smiths are pro-life public speakers advocating for children with disabilities. They also work to connect parents of children with disabilities to doctors who will give them the care that they so much deserve. So I can't wait for you to see our conversation that we had with Brad and Jesi Smith, and also sweet Faith. All right. Well, I am here right now with an amazing family, Brad and Jesi Smith and their wonderful daughter, Faith. And I'm so excited to have you guys on our webinar tonight, and so excited for people to get to meet all of you and to get to hear a little bit more about your story. So thank you so much for joining us.
It's our pleasure. We're happy to be here and appreciate that you're willing to do this and talk about these children and feature them.
Absolutely. And I'm so excited that Faith is joining us too. So I know that there was we weren't quite sure she was going to be able to join us. So I'm so glad that she's able to join us now. So let's just jump in. Brad and Jesi, I would love to have you tell us a little bit about Faith and the journey that you've been on with her.
Sure. Faith was born on December 23rd, so her birthday's coming up next week, 2008. So she will be 15 years old when we celebrate next week.
She's clapping. You can't see her, but as soon as he mentioned her birthday, she's clapping. She knows it's coming.
That's right. Happy birthday, Faith. That's right.
Thanks. Yeah, she is a sweet kid. And frankly, all of these Trisomy 18 kids are the happiest, sweetest kids you could ever meet. They just have great spirits about them. You know, they love people, and Faith especially loves to be the center of attention. So hence when you talk about her, she starts smiling.
It works that she's the youngest of our 5 too, because you want to find a great advocate for somebody with special needs. Just look to their siblings. You know, all those things that you get scared at the beginning that doctors will tell you of, oh, what will this do to other children? And we always tell other families, everything you had hoped it would. They will have soft hearts and tough minds because they are used to loving and seeing the great value of their sibling. And so what a gift she is to our family.
All of our kids have told us that that they'll take her, but we're on our own.
So they're so sweet, these children, but it does show, like, you know, I know that some parents fear, you know, what will happen to my child. Well, we have 4 older siblings that have literally, I've heard fights. Oh no, I'm taking her. I will take her if I'm, you know what I mean? So the blessing of family is not to be diminished in this at all. It is actually what makes it better, more fun, and it definitely has enhanced Faith's life.
Yeah, absolutely. Well, I'm so glad that you share that aspect, because I do think that oftentimes in this conversation around children with different abilities and you know, maybe significant health challenges, oftentimes it's talked about the toll that that's going to take on the family. You know, how difficult it's going to be for the family. And while I'm sure that you guys have had your difficulties, and I'm going to have you share some of those with us, it's so wonderful to hear what a joy Faith is in your family, what an integral part of your family she is, and the impact that she's had on your other children. What is your perspective as parents of how Faith has changed your other children's lives?
Well, I think, I mean, all of our kids have gotten, they've gotten certified to be her home health aide. So first of all, she gave them a job. She is their tiny employer at some point in their lives. We had the option of picking our own care instead of getting nursing care. My children, who are well adept to all of Faith's needs, then as they've been going to college, have a secure job with her. They know her. Interestingly, one of my daughters wants to do American Sign Language. I mean, it's kind of put them in this world we never knew about. They are the type of people that if they'll call us and say, hey, there's a family in the hospital, or we'll find out they took a family a meal. The type of compassion they have gained is what you hope your neighbor, your doctor, your employer, the people you work with would have. Again, soft heart, tough mind.
I usually say, you know, this builds compassion when you learn to work with people who can't do what everyone else can do, right? So you learn compassion. And it took me until I was almost 40 to learn the kind of compassion that my kids already have.
Wow. We're not calling him a slow learner, though. We won't call him a slow learner just because he took till 40. But my kids got that at the get-go. And life has been around kids with special needs. And what's funny is, like my kids all work with even adults with special needs, which you work with children with special needs, they're smaller, it can be a little bit easier. As people get to be adults, there's less place for them in society. And at some point, all of my kids have either done mission work or worked at camps or worked in church programs with adults with special needs. And what it shows is the value of life for each person. And they learned it young and they learned it well. And again, you will not find a more passionate advocate for my daughter or children like her than her siblings.
Yep.
Absolutely. How amazing. You know, Brad and Jesi, to hear you talk now with such positivity and to hear how Faith has blessed your family is so amazing. but I'm sure that in the beginning, when you were pregnant with Faith, and you heard her potential, health issues that she might have, I'm sure that this wasn't necessarily your outlook from the very beginning. I mean, obviously, every parent wants to hear that their child is perfectly healthy and there's nothing wrong, and that sort of thing. So, can you tell us a little bit about your pregnancy with Faith, and did you feel adequately supported by your medical team? What was your experience with your medical team during your pregnancy as you guys worked through this unexpected news that I'm sure you weren't really prepared to hear when you first heard it?
Right. Well, our OB was great. Just supported us all the way along.
He's also very pro-life and outspoken about it too. So.
Yeah, but a great doctor. Just great as what he does. So we had that support. However, in a routine ultrasound, we saw the soft signs. So you're seeing, measurements of bones and weight and
heart calcification.
Yeah, all the things they say
on the brain, different things like that.
Very typical of trisomy 18. So we ended up going to a geneticist just to get it all explained. I did not have an amniocentesis. I do not do prenatal testing because, frankly, she was already alive in my womb, and we
were pushed to. That's the thing. We were pushed to by the doctor. He wanted us to have an amniocentesis and kept saying we should have an amniocentesis. And Jesi pushed back several times going, nope, not interested. Yeah. That could cause a miscarriage. I don't want to do that.
Yeah.
And she's already at risk. Why would I do that? Mm-hmm. And he finally, I looked at him after he had said it several times. And I went, look, if we had the amniocentesis and you figured out that she had something, could you do anything to help her? And he said, well, no. So I said, well, then what's the purpose? Well, to terminate. So the entire purpose of this test wasn't to help our daughter.
According to the geneticist. This was the geneticist that we went to see to get more information. Now, he was on it. Where he was trained to identify abnormalities or genetic problems, he was right on. But his diagnosis, spot on even without the prenatal test. His prognosis was devastatingly wrong. He said it was going to ruin our marriage. Which, just ask Brad, he's so happily married. And he said it was going to ruin our 4 older children. I would say it made them. He said it was going to destroy our finances. We have like 3 insurances now. And I got to say, this is one area where I was pleasantly surprised. It has been some of the easiest. What is hardest is finding a doctor that won't discriminate against our daughter because she has disability. So I have her, and let me just be honest with you. I intermittently cussed and prayed through the first 2 years because every time I went to an appointment, it was a doomsday appointment. There was no congratulations. There was no, what a beautiful daughter. It was all like, oh, what's her quality of life going to be? Which I've become pretty hard on this point because what I know about the whole medical industry is that doctors who have very tough jobs have very high suicide rate, depression rate, substance abuse rates, and are unlikely to get help. It might affect their job. And yet here I so benevolently have never questioned their quality of life. Yet they're looking at my daughter, the very person that they were trained to help. And they have either not told us what was wrong. We had that with her short jaw. Almost 2 years old until we found out there was a reason why she wasn't breathing well. We see an ENT. First time he meets her, it's like, well, she needs a jaw distraction. She's an old lady for this because he does it on infants.
It should have been done. It should have been done when she was, in her first few months. And he was stunned that nobody had told us. But it was noted in all of her medical records.
3 separate.
Nobody told us.
And I went back and I got the records for each. It noted it, but we were never told. We were never told there was something we could do.
Darn near killed her. I mean, and I say when I say almost killed her, I mean like maybe minutes from death, where she was catatonic and couldn't move, and she was carbon dioxide poisoning like I've never seen before and haven't seen since. And so, I mean, it's really scary the way the medical profession treats these kids.
Yeah, absolutely. Well, and as a medical professional, as a physician, it breaks my heart anytime I hear stories like this of parents having to be such, parents' job, right, is to be an advocate for their children, but you also should have the support of the medical professionals that are taking care of you and your daughter. And, and I just think as you were talking, Jesi, about some of the things that you faced during your pregnancy, when you talked to that geneticist, and even after Faith was born, for families that are in your exact same situation, who maybe don't realize that they could be advocating for their child with trisomy 18
Yeah.
because they're being told that there's nothing that they can do. That would pose even a greater challenge. And it's no wonder that many families then think, well, there's nothing we can do for our child. And
Right.
so we don't want them to suffer, and I think that's a natural thing for any family, of course, right? To not want their child to suffer. And so, can you tell us a couple things? One, what are some things that other families, I know you guys do a lot of advocacy work for children with trisomy 18 and for families with children with trisomy 18. What are some things that you have heard from other families that especially, for medical professionals that are listening, that you would want medical professionals to know that they should do differently? And then just what do you think that the general public should know about having a child with trisomy 18 that maybe they don't know?
Yeah, so I would say one of the first things, especially for medical professionals, I mean, everyone needs to know the numbers that are thrown around of death rates by the first birthday. Well, that's and most of the death rates that they talk about in the womb. The death rates in the womb are where they are because of abortion, not because of miscarriages. I have seen very few miscarriages in the years I've worked with parents. I've been doing this for 15 years, and I've worked with hundreds of parents, hundreds. And so I watch for these trends in different things. And the other thing that, they'll say these kids, once they're born, that only 10% of them will make it to their first birthday. Well, let's kind of blow that out of the water, because with treatment, we actually have a study at the University of Michigan with Dr. Glenn Green, who was our ENT who did the jaw distraction. I've sent him so many kids that he now has his own study, and we have a 90% survival rate for T18 kids to the first birthday, because that's where they measure it. We have a 90% survival rate when people do full interventions to help their children. So these children, first of all, can live. This isn't some doomsday thing that none of them can survive. We know a number of people who have children older than Faith. It's not like she's the oldest at 15. So that'd be the first thing I want people to know, is there's hope. And hope with the doctors. Doctors should have hope for these children and not be doomsday. It doesn't mean it's not going to be easy. I'm not saying make it into something that it's not. It's something you're going to have to work through. But I often tell parents, this is one of the biggest things I will stress to them early on, because the first thing we see is fear. They are scared to death. And because they've been
the parents and the doctors, they're afraid to touch our children.
I mean, how many times we've seen doctors who are scared? They don't, and we've helped calm them down.
We just want them to do their job. Just whatever we'll pray, you do what you've been trained to do. We'll leave the results in God's hands.
But this applies to both parents and doctors. So if you embrace this and you work with it and you just start treating the child for what they're dealing with, you'll be able to help them, one. But guess what? You start growing under the load. The parents, I say it to them all the time, you're going to grow under the load. It'll feel overwhelming, but trust me, I've seen it happen over and over. It happened with us. We felt overwhelmed. We didn't know what we were doing.
Sure.
But the more we learned, the more we gained. You know what? Now we're helping other people. And I see that time and time again, that parents, when they embrace it and they go, this is my child, I'm going to do everything I can to help them, they become stronger. And they grow under the load, and they turn and start helping other people. But it's the same with doctors. When the doctors embrace it, I'm telling you, I've watched Dr. Green. He was a great doctor when we first met him. He is a superb doctor now. He is brilliant. He has learned so much, and it's amazing. I'm telling you.
He's also one of the first people, here they have their child. He usually sees them after they're born. But he's the first person sometimes they hear to say congratulations. And, you know, I didn't realize how devastating that was with her being my fifth, but it was so notable to me the way people acted. Like I had, you know, been in a car accident instead of just had my beautiful daughter. So, I mean, just the whole thing needs to be flipped. I guess if I was going to say something to a mom, which actually I just talked to a mom 2 days ago that's in our area, and she's going to have a baby and was given no hope. And I said, so first of all, if you have a doctor that has never had a patient live, I can't think of one other area with any of my children that I'd go, well, I'm going to go to them. They've had zero success. They don't know a standard of care. Sure, you're my person. No, find somebody who has had some success, because success is there to be had.
And I would say for parents, in terms of ways you can get that, one, reach out to us. We help parents all the time. So literally, if you've got somebody watching, they can email us, and it's just Brad Jesi. So you'll see the spelling BRADJESI at protonmail.com. So they can reach us that way. But there's a lot of help with other parents on their Facebook groups on Trisomy 18, and they're fabulous. I know, you know, so many doctors go, stay off those Facebook groups. No. Get on them.
Absolutely.
You know,
because they can suggest good doctors in your area. And because there is no medical standard of care for trisomy 18, we are literally creating the standard of care as we go. And so really, I just want somebody that's willing to do the job they've been trained to do. I mean, it is interesting. We talk about the ethics of everything else, but a fiduciary ethic that I came to pay you for these certain skills that you're refusing to give my daughter based on her disability. That is against the law. America with Disability Act says you cannot discriminate. So if even during COVID, if you guys remember this, there was a big deal because there were several hospitals that wanted to triage disabled people out of their care.
Yeah.
I mean, how horrific. That sent shockwaves through the disability community, because I'm sorry, when did my child become less human than your child? When did she become subhuman to the point that you can deny her care and to be treated like anybody else? So I think a lot of this has to do with the philosophy, the ethics, but also it has to do with the simple fiduciary. I'm paying you to do a job. When I bring my van in to be worked on, they don't keep it for a week, call me back and say, actually, you owe us this much, but we don't work on these type of vehicles. But I have been in a hospital that I found out after I was there with many tests and many appointments that they weren't even going to do surgery for my daughter, who's hitting me in the face as we speak. She's stretching.
That's right.
But I just think, you know, sometimes we have to look at people and then go, this isn't a good fit. And I wish doctors were transparent enough to say, I'm scared or I don't want to, and this is what we need to do. So
absolutely. Well, and I think what I'm hearing you guys say, and thank you so much for sharing those resources, because I know that there will be a lot of families who will hear this. No problem. Who will be so encouraged to hear that there are other families out there who have walked this walk and are 15 years into it like you all are, who can share your wisdom and hopefully share some of the pitfalls to avoid and some of the right questions to ask. So thank you so much for sharing those resources, for sharing your experience and your heart. And, you know, I think what I'm going to take away from this as a physician is, you know, we make amazing advancements when we challenge the status quo and when we don't just do what's always been done in the past. And to see a beautiful girl like Faith, and to see you guys' hearts and to hear your hearts for how you want families to be treated, how you want these children to be treated, is such an encouragement to me. I hope that it is to so many others. And I know we're running up against time right now, but I would just love, as we close, if you all could have sat down with Kate Cox and with her family when they received their diagnosis, what would be the thing that you would say to her in addition to what you've already said?
I mean, I would have said congratulations. I think that's where we start. You have a baby and they're saying incompatible with life as your child is living in the womb. So wrong, number one. I mean, at what point can I stop calling Faith, who's no longer fetal, and not fatal, right? And she's going to be 15. At what point can we take that label off these children? Because I think it dehumanizes them. So I think the biggest thing they need, that I would say to her, is there is hope. And I would say, treat this child as you would any of your other child. For any of my child, I would feed them. And for any of my child, I would say, don't overdose them. For any of my child, I would say, death is not their cure. That they should have the opportunity to live, and they have great purpose for their lives. So, and I would offer my help, and I still will.
See, that's what I said.
If this woman hears it, I am there to help. I'll go.
We will walk with you.
We'll walk with you. We'll help you find doctors. We know them in Boston. We know them in Cincinnati. We know them in Ann Arbor, Michigan. I mean, Brad has made a connection of doctors, and then you find one good doctor, and you find 12 more like him. You know, so we offer our help, but there is great hope, and there's a lot of joy in this journey.
Yep.
Thank you both so much. And please thank Faith for us too, for joining us. It was such a joy to see her and see her as she continues to grow and to thrive. And, you know, I do really hope that maybe there are families that are listening to this who are in this situation, who are, maybe they were scared and now they have hope and they have a contact that they can reach out. So Brad and Jesi, thank you so much. Continue to advocate as you're advocating for, and I know that your story and what you had to say will make a huge difference in this discussion.
Thank you. Nice speaking with you.
Thank you.
Thank you.
Wow, that was powerful. That's a family that faced uncertainty. They had a lot of fear. And as they said, they have grown under the load. And, you know, in my intro, you mentioned that I have a son with special needs. I have 3 children, and one who requires 24/7 care, who's 20 now. And, you know, I was actually in tears a couple times listening to them just now, because my Max, who has disabilities, is his siblings, his brother and sister, and even their spouses are his best advocates. And they are different people because they have a younger brother with special needs, and they're different in a great way. Just like I think I heard her say that she's made our children. I mean, that's the power. And no, it's been hard. There's been a huge load. But we're not alone in this. And I think that was a message that the Smiths clearly talked about, how they personally want to help. But, you know, even Dr. McCaffrey talked about resources for families. And I guess the last thing I'll just say that really hit me is, especially as I bring it back to Kate Cox's case, is she has older children. They're only 3 and 1 now. But should she go through with her abortion, which, you know, she may have already done, I don't know, but what those 2 other siblings will have not been able to experience by having that little girl in their home forever, however long she's there. But wow, what a great blessing to have their story of hope.
Absolutely. They were a joy to talk to. And I think, you know, it's important to emphasize that they are not a unique situation in the sense of they're not the only ones in the country that have a child who's a teenager who's living with trisomy 18. And so I think amplifying their voices and helping families who are getting this diagnosis not feel so alone is a huge part of what they're doing. And the organizations that Dr. McCaffrey talked about, Be Not Afraid and Soft, where families can go and they can receive support and access the resources that they need. So thank you for those of you who have stuck with us. And I know we're going a little over an hour, but we just want to wrap this up and help it to be relevant, not only for families that might be struggling with this diagnosis, but also to be relevant to the moment that we find ourselves in, which of course was this webinar was spurred by the case that we've been talking about in Texas. I think there's 3 kind of key things that we want to wrap up with here that we really wanted to make sure that we emphasize. The first is that trisomy 18 is not a uniformly fatal diagnosis, and we need to stop referring to it in that way. it certainly might limit a person's life, but it is not a lethal condition that no one can survive, or only survive for a short time. These kids deserve medical care, just like we see, like we talked about, in other areas, but we need to stop referring to this as a fatal diagnosis, especially to families. Susan, I think you had a thought on that based on the court filings that we have in this case.
Yeah, I think when women need to be empowered with information, and that includes an informed consent that is complete. And we don't have the medical chart of Kate Cox, but what we do have is her petition, so the legal document. And in it, at the very near the beginning, it says that when she had her amniocentesis, she was told her baby would be, in quotes, stillborn or survive for only minutes, hours, or days. And then when she was told that, she was also told that she would be forced to watch her baby suffer until death. So that's how, the medical practitioner, at least that has been reported here, provided informed consent of a baby with trisomy 18. And as hopefully we've all walked away with tonight, I know I've learned much more about trisomy 18 by participating in this educational podcast. But that's not a complete picture.
Absolutely. And it's such a false dichotomy to be giving families that are in a vulnerable situation, to say your two choices are: you can intentionally end the life of your child through an induced abortion procedure, or your child can suffer, horribly after they're born until they die. Not to mention the fact that induced abortion procedure, if it's a D&E, is going to be very, very painful for that child, as that child is dismembered through that procedure. So, to give a family that is in this, again, very difficult situation, I don't want anyone to misunderstand that our hearts are breaking for the Cox family and for what they are going through, with learning that their child had this diagnosis and not expecting that. But to then present to a family in that situation these two horrible choices, really, and to say these are your only two choices. Again, we hope that we've conveyed tonight that families should actually be offered more accurate information than that, but they should be offered better choices than that. And that would be better for them and for their children. And then the next point that we want to make is that trisomy 18 in and of itself does not pose a threat to the life of the mother. Now, again, we don't have Kate Cox's actual medical records in front of us, so we can't speak to the specifics necessarily of her case. But, one of the things that was brought up, or something that was brought up in the court filings, was that she maybe had some other conditions, maybe high blood sugars in pregnancy, or the 2 prior C-sections that she had. But we don't treat pregnancy complications by ending the life of our fetal patients when we practice medicine. We instead address those potential complications. And I think it's important to point out too, that if she were to have a life-threatening complication of her pregnancy, which again, trisomy 18 in and of itself is not, but if she were to have a legitimate life-threatening complication of her pregnancy, no state laws in the country, including those of Texas, would prevent her physicians from intervening to save her life. But those of us who practice life-affirming medicine know that can be done in a way that respects the dignity of both mom's life and her child's life. But again, I think it's important to emphasize that just an adverse prenatal diagnosis like trisomy 18 in and of itself, we heard this from Dr. Thorp, does not pose an increased risk to the life of the mother. And then our third point that we want to make is just that we believe, again, as Susan said, that families deserve accurate information. We should not be asking families to make tough decisions based on outdated data and incomplete data. Again, presenting those two options that we discussed earlier, that's not a good way to give a patient fully informed consent. I think the other thing too that I wanted to point out that Dr. McCaffrey said is that you can't put all babies with trisomy 18 into the same bucket. They are individuals, just like every one of us are individuals. And so we should not be, again, providing this inaccurate data to say that all of these babies behave exactly the same and respond to interventions in exactly the same way. But instead, we should be sharing with parents that their child actually can have a chance at life if that child is provided with the appropriate medical care. Susan, I don't know if you had any other thoughts on those three things that we wanted to be sure that we emphasized.
I think I would just add, there was a question in the chat about, I think it was from a labor and delivery nurse. How can you be assured that individuals have gotten that informed consent? And I think it's just spending time with people and hearing their story and listening and just being supportive of them. And yeah, I don't know, Christina, if you have any other suggestions on that. It's not that there is a informed consent document that's going to come with her to labor and delivery.
Right. Well, and obviously each patient is different. And, we treat and we address the issues of the patients that are sitting in front of us and take their individual characteristics and backgrounds and health histories and all of that into account. But certainly as I read through the court filing in this case, one of the things that stood out to me was that certainly, at least from what's presented in those court documents, it certainly does not seem like this family was given all of their options in many ways. And so, a way that we can ensure that families receive fully informed consent is that we present all of those options, like we talked about, and accurate information about those options, like survival rates, survival rates for these babies if they're given medical interventions. If parents are told that their child has 0% chance of survival or, a 1% chance of survival, they're going to make a different decision than if they're given the accurate information that a significant portion of these children, especially if they survive to 1 month of age, as Dr. McCaffrey was saying, can survive far beyond that. That's going to lead to a different decision for many families if they're given that information. And so that's what fully informed consent is about. So I hope that this was helpful to you all. I know that there are probably more questions that we couldn't get to, and you can still submit them in the YouTube chat, and we will try to address those at a later podcast episode. Maybe we'll put together an episode of just answering people's questions. So as we wrap up tonight, I just want to thank our guests so much, Dr. McAffrey and Dr. Thorp, as well as the Smith family for joining us, and all of you for joining us for this webinar as well. I also would like to give a huge shout out actually to our communications manager, Miriam Diallo, who put this together very quickly in the last couple of days and did a lot in the background that I wouldn't even pretend to understand. So thank you, Miriam, for all of your hard work. And if some of you joined us, halfway through this, you can watch the recording back on YouTube. Please feel free to share it with your friends, with your colleagues. If you're a medical professional, please share it with your colleagues. I think this is really important information. We're in a tough place right now culturally on this issue, and we really need to be having good, thoughtful conversations about it. We are honored to have been able to bring this information to you. Before we close, I just want to quickly bring to your attention a couple of things that AAPLOG has in the works. First of all, if you enjoyed hearing from these physicians today and hearing evidence-based information, you should know about our national conference, which is coming up at the end of February, the 23rd through the 25th in Frisco, Texas, just outside of Dallas. Our conference features nationally renowned speakers with experience and expertise in addressing the most difficult questions that are facing pro-life and pro-family medical professionals today. And this conference will equip you to tackle the difficult questions with patients, colleagues, and in the public square, and review the latest research in these areas. It's a really amazing conference and a great time to network with other medical professionals as well. If you want to learn more about that conference and register, you can go to our website, or you can go to aaplog.org/MBEC 2024. Also, I just want to mention our weekly podcast, which is titled Caring for Both, a Curbside Consult series. It's currently available on all the major podcast apps. And its goal really is similar to the goal of this webinar, to allow experts to offer insights that are useful to medical professionals seeking to lead a life-affirming practice. It's a much shorter format. It's meant to be short enough that you can listen on your way to or from work. And I'm excited to announce that starting in March of next year, we're going to be adding a video format to that podcast so you could watch it on YouTube. So if this kind of content is something that you have enjoyed, please be sure to keep an eye out for that. So thank you so much for joining us. Have a wonderful weekend and a very Merry Christmas.